JUNE's EMS training. We're going to be going over some respiratory disease processes and a little review on the physiology, how they're going to present, and the treatments for them. And then at the end, I'm going to have you guys with your crews kind of review some protocols and some medications. Specifically for this training, we're going to be talking about the respiratory disease processes for the COPD triangle, which include chronic bronchitis, emphysema, and asthma. We're going to discuss and explain when to oxygenate versus ventilate, and we're going to describe respiratory distress versus respiratory failure and the interventions needed to treat those. So let's start with respiratory distress. These can be acute, chronic, or chronic with an acute exacerbation. Interventions on these can be limited. In fact, they may even self-resolve. You think about a patient who gets some exercise-induced asthma or some COPD exasperation from going upstairs. Most of those self-resolve without us needing any intervention. These are patients who are working, but they're still maintaining. They still have the ability to compensate within their body to make up for their increased respiratory rate and decreased oxygenation. And from us, should only require minimal interventions, such as maybe a meter dose inhaler or something small. And other than that, they should be able to regulate it. Now, if we don't address respiratory distress or the causes of it, it can get worse and lead us into respiratory failure. Now, if we come across a patient who is having respiratory distress and it isn't self-resolving or resolving with minimal interventions on their part, and we head into that respiratory failure where we don't have immediate interventions, this patient can lead to respiratory arrest and then cardiac arrest. So in these patients, rapid recognition is key. And to best explain that, following the slide, there's going to be a video. And the video is a pediatric video. However, a lot of the lessons apply to adults too, and how to recognize truly respiratory distress versus respiratory failure. And on these patients, you need to address interventions quickly and efficiently, otherwise they will arrest on you.
Recognizing Respiratory Distress and Failure by Dr. Monica Kleinman.
When we say respiratory distress, we're really referring to the use of compensatory mechanisms to maintain adequate oxygenation and ventilation when something, one of many things, is causing respiratory compromise. Typically, the compensation consists of an increase in the rate and work of breathing. That increase will increase minute ventilation, allowing the child to exhale more carbon dioxide when gas exchange is impaired. Signs of respiratory distress include retractions, sternal retractions, for instance, because of the flexible, compliant breastbone, as well as intercostal retractions. And this is an example of increased effort resulting in muscles exaggerating the spaces between the ribs or in the sternum. Use of accessory muscles, such as the strap muscles in the neck, nasal flaring, and grunting, an expiratory noise that's designed to apply some PEEP. Children in respiratory distress typically are anxious. This is an uncomfortable feeling, and with that stress, they oftentimes have tachycardia. These are some examples as well of signs of respiratory distress. The child who wants to sit upright and is unable to lie flat comfortably. The child in the left looks anxious, and the child in the right is demonstrating increased work of breathing. Respiratory failure, on the other hand, is at the other end of the spectrum and is defined by inadequate oxygenation and ventilation. Essentially occurs when compensatory mechanisms fail to maintain gas exchange. Interestingly, respiratory failure can occur without preceding respiratory distress, meaning it can happen when there is depression of respiratory effort, typically by something like a poisoning, which depresses mental status, or seizures, or severe weakness, leading to inadequate respiratory effort. Signs of respiratory failure when the compensatory mechanisms are no longer able to sustain gas exchange include desaturation or cyanosis despite supplemental oxygen, the appearance of increased effort leading to poor air entry. In other words, lots of work for very little gain. This may be characterized by a sound of gasping when the child inspires, head bobbing, which is an exaggerated form of accessory muscle use in which the head literally will bob as the muscles of the neck and shoulders are trying to participate in gas exchange. Seesaw or paradoxical respirations, where the abdomen and chest move in the opposite ways than they usually do. And sounds of severe obstruction, such as stridor. The hallmark of respiratory failure, to distinguish it from respiratory distress, is a change in mental status. When oxygen levels fall and carbon dioxide rises, this is a very stressful feeling and results in sympathetic stimulation and agitation. As carbon dioxide continues to rise, it has a sedating effect on the central nervous system, leading to a child who's lethargic, sleepy, or obtunded. The child who appears to have increased work of breathing, desaturation, and sleepiness or obtundation is one in whom you need to be very concerned has transitioned from respiratory distress to respiratory failure and may progress to respiratory arrest and cardiac arrest.
So hopefully that video helped explain better than I ever could the difference between respiratory distress and respiratory failure and how to address them. This specific talk isn't going to differentiate peds versus adult. This is just a generalized overview. One thing that's important to remember is when should we be oxygenating versus when should we be ventilating? And the really difference is oxygenating is these are for respiratory distress patients. Low or high flow O2 can be done non-rebreather, nasal cannula, or a CPAP. And per protocol should be done with a patient whose SAT is 90% or below. Now that's what the protocol says. Treat your patient, not your monitor. That's an age-old adage that we like to throw around. But if your patient's statting at 91% and needs interventions, by all means, give them the interventions. Just like if your patient is at 89% and talking full paragraphs and having no problem whatsoever, they probably don't need oxygen. Then there's ventilating, which these are the respiratory failure or arrest patients. And this is high flow O2 with mechanical assistance. This is going to be your BVM or intubation or king tube or care vent. This is going to be actually mechanically assisting the body with getting air in and out. So that's our oxygenate versus ventilate. So the first disease we're going to talk about when it comes to the COPD triangle, it's going to be chronic bronchitis. Now, the clinical definition of this is excessive tracheobronchial mucus production sufficient to cause cough with expectoration for 3 or more months a year for at least 2 consecutive years. That's incredibly technical. Basically what that means is they have a productive cough for 3 or more months out of the year, 2 years in a row. Basically, these patients have increased mucus production on a chronic basis. So if you look to the picture to the left, you can see what a normal, healthy airway should look like. If you look at the picture on the bottom left side, that's going to be our patient with excessive mucus production. And you can imagine how over a chronic amount of time, that can cause a lot of problems. Now, these chronic bronchitis patients, a lot of them happen to also be emphysema patients, which we'll cover in a couple of slides. So how are these patients going to present? Well, they're going to have a productive cough. It'll be gray, green, or white mucus. Occasionally it'll have streaks of blood in it, but for the most part just a gross gray, green, productive cough. If they call us, they're probably having a shortness of breath, maybe some fatigue, which may be chronic for them. For lung sounds, you're going to have wheezes or rhonchi upon exam. And in elevated end-tidal CO2, they're going to be retaining CO2. They're going to have trouble blowing it off. Now, for our treatment, we're going to titrate oxygen as needed. Now, the old saying was don't give high flow O2 to a COPD patient because you could cause them to go into respiratory failure because of it. True. But in regards to the short-term EMS capabilities and short-term what that patient needs, if they need oxygen, give them oxygen. Do not withhold oxygen thinking you're doing them a favor. They're going to need a nebulizer with a combi vent. So this is going to be albuterol and Atrovent. That Atrovent is really going to help decrease or increase the ability for them to excrete the mucus production and really have the ability for them to cough it up. It increases the viscosity of it. And the albuterol to help open them up and get some air in there. CPAP if needed. If this patient is in severe respiratory distress and they're heading towards that failure, that respiratory failure is that light at the end of the tunnel, put a CPAP on them. You'll see remarkable turnaround. And remember, with our CPAP, you can apply a nebulizer as well. Consider epi in severe patients, that 0.3 IM epi. Also consider Solumedrol for its anti-inflammatory effects. It is a corticosteroid. With that being said, know that the onset of Solumedrol is a decent amount of time. We most likely within our transports will not see an improvement in the patient based on the Solumedrol we gave. That's really going to help them down the stream. But it's not a reason we should withhold it from them. Now I've got a clip of some lung sounds here I'm going to play. And this is going to be the rhonchi or the wheezes that you may hear in these types of patients. All right. So those are the lung sounds you could expect to hear. Also, one I forgot to mention that I'll play on this rotation is anytime there's diminished or absent lung sounds where you're just not hearing anything at all, that should be a screaming siren in the background that that patient is imminently in respiratory arrest. They've moved past distress, they are in deep failure, and arrest is imminent. So anytime you can not really hear anything or hear diminished, that is a time to really, pick it up and boogie on down the road of more severe treatments. So now we're on emphysema. The physiology of emphysema, airspace, the alveoli, which is in our lungs, which allows for gas exchange, they're damaged. The inner walls weaken and rupture, creating large air spaces. These are your classic air trappers. These are patients who have that pursed lip breathing. They tripod, and they're trying to get that air out. They just can't get. They're trying to create, basically, when they pursed lip breathe, they're creating their own PEEP, is basically what they're doing. This is most often in emphysema. We see it mostly with smokers, but it can also happen to people who had chronic exposure to air pollution or who worked in areas where there was fumes or dust and they didn't have proper respiratory protection throughout their careers. Their presentation, like I said, pursed lip breathing, they might be tripoding, they're going to have that obvious shortness of breath. They're going to have the wheezes or diminished or absent as well. That could happen. Elevated end tidal CO2 for the same reason as your chronic bronchitis patients. They're air trapping. They can't get it out. So once, normal end tidal CO2 is 35 to 45. It's not uncommon to see a patient with COPD who's having trouble in the 50s or 60s. And that's, really, we're past distress and we're moving in towards failure. Once you get into the 70s, 80s, 90s, you're deep into respiratory failure and you're almost in imminent arrest. So you really need to put an early end tidal on these patients and address it quickly and try to get that end tidal CO2 down if you can. Treatment. Titrate oxygen as needed, much like I said in the last one. Like if they need O2, give them O2. Nebulizer with combi vent. And it really helps with the CPAP, with the neb, because it really allows us to get that medicine deep down in there. So now if you don't use a CPAP and you just use a nebulizer, like the old peace pipe, or you put it on the mask and you have them breathe it in, they really need to breathe deep because every time they get that breath a little bit deeper, it gets that medicine a little bit deeper. Consider epi-IM in these patients. Use caution on patients with a history of cardiac disorder. Once again, though, risk versus benefit. If they're going to die, if I don't do something quickly, give them a shot of epi in the shoulder. Worry about the cardiac side effects later. It's not going to matter what the cardiac side effect is if they go into arrest. At times, these patients can benefit from mag sulfate too, a couple of grams. It's not for every patient. It is a smooth muscle relaxant, so you have to be careful with how quickly you get it, and that's really going to be the medic's decision whether to do that or not. But that's at the bottom of our tree, of our algorithm of what to do. Also, consider salmeterol once again. It's a corticosteroid. It's going to help reduce inflammation. Not immediately for us, but it'll definitely help them probably by the time you get to the hospital. And it's one less thing they're going to need when they're there. And following this clip, I'm going to have the diminished lung sound for you because I forgot it on the last one, and then we're going to talk about asthma. So the last part of the COPD triangle is asthma. This will probably be one we come across most often. It's a condition in which the airways narrow and swell and produce excess mucus. So if you look there at that photo, the pathology of asthma, you can see kind of the normal airway on the left, a chronic asthmatic in the middle there, and then when they're having a severe attack, all the way to the right. So you can imagine how much that constricts the airway and how hard it is to breathe. And this is common. This is in 7.7% of adults and 8.4% of children within the US. So we will see it. A large amount of 911 calls, especially for pediatrics, are from asthma exacerbation. So presentation, they're going to be wheezing, or maybe absent or diminished lung sounds if they don't have any room left in there. They'll probably be tripoding. They'll have that look of impending doom on their face if they're in uh, severe asthmatic status asthmaticus. They very often will have their own meter dose inhaler and have tried multiple hits on that to no effect. And the triggers on this can be various. So a lot of times patients, especially children with asthma, when they have other viral illnesses, which as we all know, children are just walking petri dishes of viral illnesses, can trigger asthma attacks. You can have exercise-induced asthma attacks where somebody goes out for a jog or even just up the stairs and it triggers it. Those can usually be handled with just one or two puffs off the meter dose inhaler and they'll be okay. Also, outdoor allergens. Once that pollen really starts kicking here, that can trigger asthma attacks, as well as dust and things like that. In fact, it's worth noting the number one thing seen post massive earthquake and disaster is not trauma. The number one thing that we see in the pre-hospital and the hospital field post disaster is upper respiratory infection, most commonly asthma, caused by just the dust in the air. Our treatments. These look a lot like our others, and that's probably because they all fall under the same protocol, which is our adult wheezing protocol. Titrate oxygen as needed. Meter dose inhaler if they have prescribed. Obviously, we just don't go giving out inhalers, but if they have one, help them. If they have one, give it to them, especially now in the time of COVID. We're trying to reduce our aerosolized generating procedures, so we're trying not to use our nebs anymore. So a meter dose inhaler reduces the aerosols in the air. Use it. Bring it with you to the hospital. Very important right now. If for some reason they don't have their MDI or it's out, it's empty, go ahead with the nebulizer. Once again, CombiVent is going to be great for these patients. It's going to help increase the viscosity of that mucus and help them get it up. CPAP if needed. Asthmatics can benefit greatly from having CPAP applied. Consider your epi. Once again, these patients do great with IM epi. Consider mag sulfate. Mag sulfate, I've seen many patients, including children, turn around significantly having a severe asthma attack due to mag sulfate. Now, mag has its own downsides and side effects, like you can't push it too quick. You can cause some respiratory depression. So that's strictly a medic skill. And salmeterol is going to be huge. Many of these chronic asthmatics who have severe flare-ups are already on steroids most of the time. So salmeterol is going to be great for these people. Get it on board early so they can start to see the effects quickly. So that was a very brief overview, guys. We're trying to keep it short. We're trying to keep these about between 20 and 30 minutes long so as to not give you death by PowerPoint, or in this case, death by video. We're trying a new thing here because we've had some issues with the PowerPoint presentations and the videos and everything recording. So we're going to try it this way. A lot of this is going to be after the fact. So go back with your crews, medics, Get with your crews. My Wildland crew up top there. Get with your part timers and go over these things. Some protocols to review. I'd really like you just to review the respiratory protocol section, 2000, 2010, 20, 30, 40, and go over those various protocols and, importantly, what EMTs can do and what medics can do, because the EMTs can do quite a bit for these patients, especially with the updates in the Chapter 2, which is the state EMS guidelines. EMTs are allowed to do more now. So go over this with them. It's really important. Uh, Respiratory calls, last statistic I saw was it makes up about 12 to 13% of the calls we run pre-hospital, so we're going to come across them. Also, while you're pulling out the old protocol book or the app, go over the medications. Albuterol, Atrovent, Solumedrol, mag sulfate, and epi. Specifically in regards to respiratory calls, you don't need to go over epi for cardiac arrests. I just want the IM doses here. And that'll do it. So medics, go work with your crews, maybe run a few scenarios, go over some equipment, medication dosings, the meds, and run through a few respiratory patient scenarios. I hope you guys like this. We're hoping to push out some more of this type of stuff. And enjoy. Any questions or comments, concerns, address them to Chief Johnson or Chief PV. Thank you.